Good afternoon, everybody on the East Coast, and good morning to everybody on the West Coast, and to wherever you are. Hello. Thank you for joining us for today for our Let's Talk series on Alzheimer's disease, what it is, how early it is, how it starts, I should say, and what we can do with Dr. Gary Kaplan. We're really excited for today's session, so thank you for joining us. And I wanted to just share a little bit about Dr. Gary Kaplan. If you are not familiar with him, if he's not your doctor, if you just stumbled upon us today, he has over 40 clinical years of experience treating and diagnosing immune-mediated chronic illnesses. So that definitely makes him a pioneer and leader in the field of integrative medicine. Dr. Gary has been talking about things that are just now coming to light for the longest time. So we're excited to further share that information. He's also only one of 19 physicians in the country to be board certified in both family and pain medicine. He's an associate professor at Georgetown University and the author of 2 books, Total Recovery and Why You're Still Sick. And then we are going to, just to get a lay of the land of everyone, if I can go to the next slide, please. How everyone joined us today, where you're coming from, what your current situation is. So your information will not be shared with anybody. It will be completely kept private. We're not going to try to market you with the answers you gave us. I won't know who said what. We are also recording this session, so that way we will be able to sharing the information. But again, please know that your information isn't being shared. So our icebreaker. So what brings you today to our webinar? Do you have concerns about your own memory? Are you supporting a loved one? Were you recently diagnosed? Are you just looking to prevent, learn more information? And then how worried are you about cognitive decline? Not at all, maybe a little concerned, starting to get a little bit more concerned, or are you very concerned? I would definitely be concerned because it is a very serious disease, and maybe you knew or did not know that research suggests that brain changes can begin 10 to 20 years before symptoms appear, which makes early diagnosis possible and much more possible and makes treatment options more available to us. So we're happy that there's more research being done on this topic, and I'll share what we have here. So it looks like we have a pretty even split about the types of participants we have here so far. No, not everyone's here just yet, but 30% of people seem to be concerned about their own memory, 30 for a loved one, 40 that are just looking to learn and prevent. And then the concern seems all around the room. So there's no one that responded that they're not at all concerned, which is great to hear, which means we're being proactive in whatever stage that we're in. So enough of me talking. I'm going to pass it over to the star of the show today, Dr. Gary Kaplan. I will share that at the end of his presentation, which today is about 45 minutes. We will have Q&A. It'll be about 15 minutes or so. I hope that you can stay on a little bit to get that. If we don't cover everything that we wanted to cover in terms of your questions, just know that we'll follow up and share more information on that in an email if you registered. I'll also send a recap email about things that we cover today. So with that, I will pass it to Dr. Gary.
I got to thank you. So we've got a lot of ground to cover today. I want to make one thing clear, that this disease is very personal for me. This is a disease that took my mother, and this is a disease with my wife is suffering with. So I have massive motivation in terms of not just understanding what this disease is, but in trying to find better solutions for it. Dementia itself is an umbrella term. It's a syndrome. It's a collection of symptoms, so it's not so much a single disease. It talks about a decline in memory, thinking, functioning, executive decision-making, significant enough to interfere with your life. Okay? So Alzheimer's is hands down the most common cause, but it's not the only cause. Alzheimer's typically runs about 60 to 80% of all the dementias that we see, but there are other things called Lewy body dementia. There's Parkinson's disease, which is most frequently associated with Lewy body dementia, frontotemporal dementia, which all these typically occur earlier, vascular dementias, which occur later. But You can also have very treatable things, such as normal pressure hydrocephalus, which you can treat with shunt. Creutzfeldt-Jacobs disease is a complete disaster and a fairly rapidly developing disease. Huntington's disease is another disastrous neurologic problem. So unfortunately, many of these don't have a lot of good answers. Uh, Next slide, please. So, what's normal aging versus mild cognitive impairment versus Alzheimer's? And there are stages, okay? So, normal aging is you forget a name, but you remember it later, okay? Why did I come in here? What was I coming in here for? If you're forgetting a name, by the way, and remembering it later, I personally would have been diagnosed with Alzheimer's probably when I was 10. So, this is just the normal.
And Dr. Gary, can you just turn on your mic? Sorry.
Ah,
There we go. Sorry about that.
did you get any of my stuff?
Maybe just the last 10 seconds were missed.
Okay. So this is, distinguishing between normal aging and mild cognitive impairment. So it's extremely important because forgetting a few things isn't a big deal. Forgetting a lot of things and where you're having into problems with your independence, with your daily activities, that's another story also. So early cognitive impairment shows up where you're not remembering appointments. You're potentially uh, getting a little bit disoriented. You may have problems doing the work that you've done for years, and all of a sudden it gets harder. You start making more mistakes. So this is now interfering with your life. Alzheimer's itself becomes a whole nother story. Alzheimer's becomes a point where you can't navigate around strange environments. You can't remember your appointments. You can write them down and then you forget where you wrote them down. You're constantly asking the same questions over. You may be repeating the same stories over. People around you will start to notice. Early on, people meet you in a restaurant or just for an evening may not notice much, but those who are around you on a regular basis will absolutely be able to notice what's going on. So this is early stage Alzheimer's. There are 4 stages of Alzheimer's, and the fourth stage, of course, is where you're basically bedbound and completely disconnected from your environment and unable to care for yourself. Next slide, please. The red flags, the things that you want to pay attention to, we just started talking about. So if you're repeating the same question within a single conversation, if you're getting lost in familiar places, if you're missing medications or paying your bills, all right, things are piling up. Personality changes, anxiety, depression can be the beginnings of Alzheimer's. Apathy, you become paranoid, irritable, things which are particularly out of character. Things that happen rapidly in terms of personality disorders, okay, are not typical of Alzheimer's. So in those situations, you need to think about either a post-concussion syndrome or an autoimmune encephalopathy, subdural hematomas. Those things need more urgent workup. These are gradual progressive changes that literally occur over months and years, not in a matter of weeks. So if something is changing rapidly, that needs urgent workup. Next slide, please. And it's not just amyloid. So we got stuck on the amyloid hypothesis for decades, and we were wrong. Amyloid is the symptom of, it is not the disease. The disease is an underlying destruction of the neuronal passages, typically through tau tangles. And amyloid is the substance that builds up as a result of all the inflammation going on in the central nervous system. So, yeah, it's neurodegenerative, but it's also neuroinflammatory. And because we now know this is a neuroinflammatory disease, we can think about it differently, we can treat it differently, and we can get better results. So, we know from early studies that amyloid can build up in the brain and not cause dementia. So, back in the early 2000s, there was a big study done on nuns where they found at autopsy, while there was a significant amount of amyloid in their brains, they had no evidence of Alzheimer's. They had no evidence of any neurodegenerative disease. So also, so amyloid does not equal Alzheimer's, but amyloid in conjunction with memory disturbances and another picture, more comprehensive clinical picture, yes, then we'll equate that with the presence of Alzheimer's disease. So you need to make sure that we've got the right disease, and we need to make sure that we've got a complete understanding, which is evolving rapidly, about what the disease is. Tau is a protein that normally stabilizes microtubules. Those are the things that run inside the neurons themselves, transporting a whole variety of substances, including neurotransmitters. They become hyperphosphorylated. They detach and form tangles inside the neurons, and thus the neurons stop operating. So in Alzheimer's disease, we're looking at a tau disease, and we're looking at a neuroinflammatory process that has caused that. Amyloid builds up between the cells, while tau builds up inside the cells. So tau spreads, tracks cognitive decline much, much more closely than amyloid spread does. Next slide, please. The other thing is this disease begins long before the symptoms show up. Okay. In that regard, it's not a whole bunch different than cancer. Cancer cells are developing and growing years typically before you actually get the symptoms of the disease. That's why we do everything we can for early detection, because the sooner we can find the disease, the sooner we can treat it, the higher the probability of complete cure. So we're not to cure yet with Alzheimer's, but we've got a lot of early warning signals that we can look at and start intervening with. So there's about 10 to 20 years of a silent biologic process, a degeneration going on in your brain, where amyloid is building up, inflammation is rising, tau is spreading, and synapses are dying. So you've got a lot of reserve capacity in your brain, but our objective is to identify this as early as possible so that we can intervene. All right. There's a DINA study where amyloid PET positive showed 20 years before the symptoms of inherited Alzheimer's disease showed up. So by the time the memory problems appear, we're really late to the party. The disease is well underway, and our objective is to get there much sooner. The good news is we have the tools now to diagnose this much earlier. I know people are terrified with the thought of a diagnosis of Alzheimer's. It really is a frightening disease. I know firsthand. But I also know that the sooner we can diagnose it, the same as the sooner we can diagnose cancer, the higher the probability that we can slow, potentially prevent the expression of the disease, and I believe we will actually get to the point of being able to prevent the occurrence of the disease. Next slide, please. So since we can detect amyloid, or we can detect Alzheimer's years ahead of time, how do we do so? Well, there's a number of ways. So there's an amyloid PET and tau PETs that can be done. So positive electron emission testing can be done, or proton electron emission testing can be done. Very expensive, not a standard screening tool. We can check for biomarkers in the cerebral spinal fluid, which requires a spinal tap. Those are highly accurate. We can now do blood biomarkers, and that's an extremely important thing to understand, because the biomarkers we can now test in the office. So we can test for phosphorylated tau 217. This is an FDA cleared test, as well as a ratio of amyloid beta 42. So these tests give us, along with the clinical findings, give us some indication as to whether or not we have a disease that's ongoing. So the blood testing performs pretty much as well as the CSF at this point in time. And while it's not a population screening tool, meaning if you don't have any symptoms and we don't have any reasons for checking that on you, used in the right clinical context, it can give us really early indicators of what's going on. Next slide, please. So here's the picture you want to keep in mind. All right. The red line where you see mild cognitive impairment showing up, look at how long before the disease onset that we see the development of degeneration occurring in the nervous system. Okay? This is 15 to 20 years before the disease actually shows up. So we have a big window where there's a lot we can do to prevent this from happening. And since we know it's a neuroinflammatory disease, and that's what we happen to do around here for the last 20, 30 years, we can do a lot to intervene to potentially prevent the occurrence of progression of the disease. Mild Alzheimer's develops sometime after the mild cognitive impairment, and then moderate severe sometime after that. Each individual is a little bit different in how fast, but typically an 8-year period is about the average from onset of mild Alzheimer's to severe disease. Next slide, please. So how do you diagnose? Careful clinical evaluation. The standard cognitive testing, the MoCA, being the one most accepted. So easy to administer, no big deal, and a way of determining whether or not there's problems we need to start thinking about. I would put labs prior to MRI testing. So we're looking at thyroid, we're looking at B12 folic acid levels. B12 levels alone is going to give you a lot of neuropathic problems. Syphilis, I have to tell you, it's on the rise. And so RPRs are really essential as part of the workup. And an appropriate risk group, HIV testing is appropriate as well. Autoimmune encephalitis and antibody panels can be appropriate, as well as examination of the cerebral spinal fluid. MRIs, when appropriate, we're looking for atrophy. And we do an MRI now that's looking for changes in the size of certain structures within the brain, such as the hippocampal area. And we're also ruling out other problems, brain tumors, that may be causing the problem. So we see enlargement of the ventricles, we see deepening of the sulci as inflamed brains progress. So there's a lot we can see on an MRI, and it's an easy enough test to get. The biomarkers that we talked about a little earlier about p-tau, and amyloid beta ratios are another thing that we can do. And always, 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 we're looking to see what we can find that's reversible, that's being mistaken for Alzheimer's. Next slide, please. Simple things, sleep apnea. About 5% of the population has it, and 85% of that population isn't diagnosed. So if you're having problems with sleep apnea, that absolutely has to be checked and treated if that's the problem. Sleep apnea is going to result in inflaming your brain. It cuts off oxygen to your brain, and it's going to cause any neurodegenerative process to progress rapidly. Depression itself, medication side effects that you need to pay attention to, can also cause changes in cognition. B12, hypothyroidism, which we've already talked about, hyponatremia, low sodium, which can occur in certain disease processes. Normal pressure hydrocephalus, again, with that, we're going to be seeing more issues with gait disturbances. We're going to see problems with urinary problems such as incontinence. And sometimes we can treat this neurosurgically with a shunt to relieve the pressure. So that's another thing that needs to be considered. Chronic subdural hematomas, especially in older patients who have been on anticoagulants, but people who have taken repetitive blows to their head, we need to make sure that there's not a subdural. That can be done easily enough with a CT scan. Autoimmune encephalitis, those are looking for very specific antibodies that can be treated potentially with intravenous immunoglobulin, therapeutic plasma exchange, or rituximab. Autoimmune encephalitis, I want to point out, is a different disease than autoimmune encephalopathy, which is what we treat a great deal of. All right, so it's a less inflammatory process, though it is an inflammatory process in encephalopathy, but it's more chronic in nature and it's more reversible, okay? And it's not as urgent as the encephalitis is. Lyme disease. Lyme disease can masquerade as Alzheimer's, and there's been a number of cases. Chris Christopherson was one of the most famous, where in fact they was originally diagnosed with Alzheimer's disease, but found to have Lyme disease. When treated, he recovered dramatically. So things you gotta, if you don't think about it, you don't make the diagnosis. If you're paying attention, you can ask the right questions, do the right tests, and potentially find a treatable condition that can save your life. Next slide, please. All right, let's talk about genetics. Okay, so ApoE is an apolipoprotein. This one is E. There are several of them, and they come in varieties of 2, 3, and 4. All right, you get one from mom, one from dad. Right. So the allele frequency, the EE is the most common. ApoE33 is about 60% of the population. Uh, if you have one of the fours, that's about 20% of the population. If you have two of the fours, that's only 1 to 2% of the population. And unfortunately, that's the highest risk of developing Alzheimer's. So if you look at lifetime risk, because ApoE is about programming for an enzyme that helps clear amyloid from the brain, aside from anything else. So ApoE2 is typically protective and lower than baseline, which is what we regard as ApoE33. Your risk, if you have one of the ApoE4 alleles, now moves up to about 2 to 3 times. Onset tends to be a few years earlier. And if you have both the ApoE44s, that's a 10 to 15 times risk with a 10-year earlier onset. And it's proposed as a genetic form of Alzheimer's disease. It is not deterministic. You can have an ApoE44 and never develop Alzheimer's, but it does put you at a higher risk. So lifestyle and other genes still matter. It's also important to look at family planning and counseling, especially if your parents have had Alzheimer's and there's a strong family lineage of Alzheimer's. In my case, my mother had it, my grandmother had it, my aunt on my mother's side had it. So it's a very strong female predominance in my family. Next slide, please. So again, if you look at the presentations of an ApoE22, lowest risk, ApoE23 is a lower risk, ApoE24, slightly higher risk, ApoE33, that's kind of the average, okay, without an increased risk in the population. But as soon as we get to the 3/4s, higher risk, and the 4/4s, we're at a dramatically higher risk of developing this disease. Does this mean you're going to get it? No, but it does mean we want to be more aggressive in watching you and making sure that we can address all of the modifiable factors that can potentially slow or even prevent the onset of this disease. Next slide, please. So Lancet recently came out with a paper that identified 14 modifiable risk factors and suggested that up to 45% of dementia was preventable or delayable. Okay? 14 factors, we can treat these things. In midlife, if you're dealing with hearing loss, single highest risk factor, get it treated. Treating hearing loss with hearing aid actually reduces your risk of Alzheimer's. Hypertension needs to be treated. Obesity needs to be treated. And in fact, utilizing some of the GLP drugs, it not only looks like will reduce obesity, but it looks like it may be neuroprotective and heart and kidney protective. Recent study looking at the GLP-1s for the treatment of Alzheimer's essentially failed. But that's, I think, after the horses left the barn. What we really need to look at is what we can do in modifying these things much earlier in life. And the GLP drugs are probably going to be the first true longevity health span drugs approved on the market. Alcohol use, we've finally concluded that basically any amount of alcohol is bad for the brain. So true moderation, but less is dramatically more. Head injuries, repetitive head injuries, we know will cause neuroinflammation. We also know that people who have been suffering with depression for extremely long periods of time, even treated, have a much higher risk of developing Alzheimer's. So we can treat this stuff. We want to pay attention to it. Later in life, physical inactivity is a real problem. Physical activity, exercise is probably one of the single most anti-inflammatory things you can do for your whole body, let alone your brain. Smoking, just a disaster in all regards, and stop as soon as possible if you are. Vaping, no better. So smoking is something that you really want to eradicate as a problem. Social isolation is a big deal. One of the big determinants of longevity, health span, is good social connections. So the more socially isolated you are, the higher the probability of developing this disease. Diabetes, absolutely a problem. Now, very interesting is air pollution. And it turns out that people who live in high air pollution environments have a much higher risk of developing Alzheimer's than those who don't. So where you live counts as far as your risk for development of Alzheimer's. Additionally, we now look at specifically the low density lipoprotein cholesterol that needs to be addressed. That can easily be addressed with statins. And statin medications, by the way, do not cause Alzheimer's. The most recent data showing on statins show that they're anti-inflammatory and suggest they may, in fact, be neuroprotective. So treating the LDL cholesterols with diet, treating them with statins is completely appropriate, safe, and probably neuroprotective. Untreated vision loss. Again, as your world gets smaller because you can't hear and you can't see, your brain starts to shut down. And so it's important that we keep you as stimulated as possible, visually, auditorily, physically, and socially. So all of these things, you learning new things, we know helps the brain. It is simply, it's you want to exercise the brain like you exercise any muscle. And so all the ways that you can do that are going to be helpful. Learning new things, learning a language, learning something that you don't typically teach yourself, learning a new skill, both a physical skill such as doing Tai Chi or Qigong, as well as doing new cognitive skills. Dietary wise, the Mind diet and the Mediterranean diet have been shown to be both effective in terms of reducing the risk of Alzheimer's and slowing its progression. Sleep apnea, as we discussed, if you got it, treat it. There's a thing called an Epworth scale, and it's very important that you determine if you have sleep apnea. Epworth scales are available online. It's a quick questionnaire. Fill it out. If you score 10 or more, get to your doctor ASAP and say, I think I have a problem. Foundational health, the floor on top of which any drug therapy is built. So getting good sleep, getting good exercise, good dietary habits, good social networks. All of these things are crucial. Meditation, all of these things can help keep you alive longer, healthier, and with greater vitality. Next slide, please. Omega-3s, so we're going to look at supplements for a second. The omega-3s, the evidence is mixed. Best is part of a Mediterranean diet. But I think that the omega-3s, in terms of helping for prevention of heart disease, other benefits from them. So you can potentially get significant improvement from omega-3s for heart health. About 1,500 milligrams a day would be the diagnosis, and they should be mixed. Vitamin E is a little bit trickier. It does seem to slow the risk of Alzheimer's disease or the progression of the disease, but it also carries a high cardiovascular risk. So you want to pay attention to how high your vitamin D levels are. We can measure vitamin E levels, and so checking to see how much you're getting. So I wouldn't just supplement it. I would instead check your vitamin E levels and supplement accordingly. I would probably lean more toward the 400 IUs a day as a supplement, and certainly not be doing 2,000 a day unless I had very clear indications. B vitamins can slow atrophy. You want to look at whether or not you have an elevated homocysteine. That should be part of your normal lab work, as well as checking for adequate levels of omega-3s. But B vitamins, folic acid, B6. B6, by the way, too much B6, and you can end up with neuropathies from it. So all of these things, we should measure them and then treat accordingly. any other supplements, there's a lot of stuff claiming, but the reality is it's not proven. I will warn you very specifically about brain honey. I watched an infomercial on brain honey not too long ago. It was hosted by Bill Gates. And I'm sitting there going, why on earth would be Bill Gates be doing this? He has spent a great deal of money on Alzheimer's research, and why he's now doing an infomercial for brain honey. It is a complete, total, deep fake. So you need to be careful about these things and way watch for people over-promising, under-delivering, or just plain fraudulent. Next slide, please. Let's talk about the anti-amyloid drugs and their safety and problems. Okay. A recent study came out and grouped all of the anti-amyloid drugs together and said they don't work. Now, there's criticism of this study. It was a Cochrane collaborative study. There's criticism of the study saying, well, no, you can't include all the drugs that we know didn't work. You have to pull out the ones that did, signal from noise argument. All right. And lecanemab has shown that it is capable of slowing the disease somewhat, 27% on a good day. That amounts to about a 5-month delay in the progression of the disease. This does not cure the disease. It slows its progression. Donanemab also has a little bit better showing, but again, it slows the disease. It does not reverse the disease. These drugs have potentially very severe side effects. Okay. ARIA, lovely sounding word, E and H. E is edema, that is brain swelling. ARIA H is microhemorrhages. We need to be more thoughtful about how we're using these drugs, because the fact of the matter is people with ApoE44, which is the case for my wife, are the highest risk in terms of developing ARIA, a little bit higher on donanemab than lecanemab. But the reality of the matter is when it happens, it's a mess. And so they'll tell you that, excuse me, one second. They'll tell you that, typically these are non-clinical problems that we see it because we monitor using the MRI. You monitor, by the time you find the quote unquote non-clinical problems, there really are clinical problems. There's this worsening of the disease. There could be headaches. This is not a benign thing when you have bleeds in your brain and you have swelling in your brain. I don't think the ApoE44 genotypes should be treated with these drugs. My wife, unfortunately, developed both ARIAs and is no longer eligible for these drugs. So I am suspicious of these drugs. I will also tell you that studies have shown a complete elimination of amyloid in the brain with these drugs, and yet no further improvement in the disease and no better slowing of the disease than the original studies. So I have great suspicion about these two drugs, even though they're approved. And I think we're not clear yet about who they can best serve. You want to do it in early symptomatic disease, biomarker confirmed. Again, as I said, we need to stratify by ApoEs, and it has to be monitored closely with an MRI. Next slide, please. Now, there are other studies that are actually quite promising that don't focus on amyloid. So, therapeutic plasma exchange. The AMBER study looked at plasma exchange plus albumin replacement over a 14-month period with people with early cognitive decline and early Alzheimer's. We saw a slowing of the disease by 52 to 66%, which translates out to about 7 to 9 month delay. That's a whole bunch better than what we're seeing with the studies with the anti-amyloid drugs. In addition, mild diseases were less clear, but clearly an improvement. The challenge with this drug is that, or this therapy, is that it's not FDA approved. It's not yet approved for Alzheimer's. And so we can see a difference in terms of cost for this drug. So it's a costly process. It can be done outpatient. It's a safe process. We don't see ARIAs developing with this. And certainly in my own personal experience, I've seen this dramatically improve the damage that was done from the lecanemab donanemab. So Alzheimer's is going to move from beyond removing amyloid into removing inflammatory complexes, which is what plasma exchange does. Again, I'm not telling you this is a cure for the disease, but the early data on it is extremely promising. Our experience with it has been reinforcing that promise, and the risk is extremely low. Done outpatient, fairly simple procedure to accomplish. Next slide, please. Another drug which is now available for what's called uh, uh, see, this is what happens in early memory loss. It's approved by the FDA for compassionate use. Compassionate use means that the drug has proven itself to be safe. The drug may or may not work because it's not done with stage 3 trials yet, but has moved along far enough that says it may be helpful. And uh, this is also not going to be covered by insurance. But it's a monoclonal antibodies targeting galactin 3. Galactin 3 activates immune cells and drives neuroinflammation, contributes to the progression of the disease. So it's a different mechanism of action than the anti-amyloid drugs. It's targeting the inflammatory environment itself. All right. In preclinical trials, very strong signals of reducing pathology and improvement in cognition. Early human open label trials, about 50% of the patients stabilized or improved. 50%. It's not randomized and blinded yet, so it's a registered trial that's yet to be read out. It's also being studied in Parkinson's disease because of a shared neuroinflammatory pathway. It's extremely promising. It's only available for centers that are part of an IRB, that is part of the research on this drug. It is not covered by insurance. We are one of the centers covered on this IRB. So we can treat people with Alzheimer's with this drug. It's administered IV, typically once a month. Very, very low side effects. Looks like a safe drug. We also can do some additional genetic testing to determine whether or not you're a good candidate for this drug. So we can get a little bit more specific about who's going to benefit and who won't benefit from this drug. So much safer than the anti-amyloid drugs, and we think may actually targets a completely different part of the pathology. I think it holds great promise, which is why we're part of this study and involved in this. Again, it is an out-of-pocket expense, unfortunately, but available for those who have not been successful with other therapies. Next slide, please. This just goes over what I was just talking about. It's an IV drug, intravenous drug. It's given every other 8 days. While the risks are not fully characterized, those identified to date, and it's been around for a couple of years now, are pretty safe. And we're not really seeing the area developing in this crew that is occurring in the other drugs. Next slide, please. What's on the horizon? Well, the GLP-1 agonist that we talked about, semaglutide, tirzepatide. So those are showing metabolic and anti-inflammatory, widely available, well tolerated. Certainly, I look at this drug as preventive and would encourage pretty much anybody to be using it. We're using it at smaller doses, which have not yet been subjected to study, but at least it's not causing weight loss. We're really interested in the metabolic benefits from the drug. And we can measure and see some metabolic benefits on the blood markers that we're checking. Transcranial magnetic stim has shown modest benefit, especially with cognitive training. This is where we put big magnets on you. It takes about 10 minutes. It has to be done in a center that has a transcranial magnetic stim. It again is not approved on out of pocket expense. But again, we haven't got a lot of options here. And so I encourage people, when other things are not working, to consider transcranial magnetic stimulation. The tau-directed therapies we've already talked about, microglial modulation. These are things that are going to be doing beyond TB006. But microglial modulation, I wrote a book on it called uh, Why You're Still Sick and Total Recovery. Those books were focusing on reduction of inflammation in the central nervous system, especially regarding microglia. Combined therapy is probably going to be the answer, meaning that we'll layer the therapies much the same way we do in HIV and cancer. So for the moment, it's about a little of this, a little of that, everything we can do in order to be able to stop the inflammatory process or modulate the inflammatory process, and everything we can do to back you off the progression of the disease. So I think within the next 5 years, this will be a disease that we will in fact treat as a chronic issue and not as a death sentence. And I think within 10 years, pretty much we'll have this disease resolved. Next slide, please. So here's the word. If you're worried about a family member or yourself, don't wait. Get a proper evaluation, get labs, if necessary, get an MRI. Let's make sure we're dealing with reversible causes so that we can, in fact, do something to get you better and dramatically improve the quality of your life. You want to make sure you're treating blood pressure. You want to make sure that your sleep is protected. You want to make sure that your metabolic health is protected. The 14 things we talked about in the Lancet study, what you can do in order to keep yourself healthy, hearing, vision, exercise, all of those things. When appropriate, we want to be doing biomarker testing before settling on a diagnosis. We want to consider anti-amyloid drugs, but if you're going to do that, we need to make sure you've got your genetic typing. I think this is a disease that it's time to get our heads out of the sand and start being proactive with the risk factors that we now know can cause this disease to progress. And we want to know our genetics. I know you get terrified getting some of this information, but at the same time, if you keep your head in the sand, you're going to get run over by that truck that's coming down the path. You want to make sure that you know what your risk factors are and what we can do to intervene. Healthspan isn't about necessarily preventing all disease. It's about identifying any diseases as early as possible so that we can intervene with the highest probability of a cure. And that's what we want to be doing here as well. You want to be skeptical about supplements promising too much, but there is modest evidence evolving on a regular basis that there are supplements, such as things that help with mitochondrial function, CoQ10, UBQH. There's evidence of using omega-9s that can also be very helpful. So I think that while we want to be skeptical of supplements, at the same time, we want to be open to the possibility. Low risk, high reward, worth a consideration. You want to stay engaged. You want to cognitive activity, social activity. You want to be exercising. You want to be attentive to your diet and your sleep. These are the things that we want to pay attention to. Stop smoking if you're smoking. Alcohol, really reduce your consumption of it, if at all. All right. These are the things that this is in your power to make a difference in your health and your health span. Next slide, please. So, big picture, Alzheimer's disease starts years, decades before the symptoms show up. It's not just amyloid. Amyloid is there, yes, but it's also about tau, neuroinflammation. We can have vascular disease, metabolic, and synaptic disease. We can detect it earlier than ever before. Lifestyle accounts for nearly 1/2 of the modifiable risk. Drugs can slow the decline modestly in selected patients with real risk. New therapies are emerging rapidly. Okay, the anti-galactan drugs that we just talked about, the GLP-1s, the plasma exchange, microglial modulation. And the plasma exchange, I'll put in a plug for also, because we looked at plasma exchange for health span in healthy individuals. And what we found was that doing therapeutic plasma exchange with replacing a little bit of gamma globulin was the aging clocks, we have a number of ways to measure how fast your biology is progressing, and not just overall, but in each individual organ system. We found that we were able to reduce the aging clocks by about 2.5 years. So that if you're 50 years old, you get a setback to about 48, 46. All right. So we want to pay attention to the fact that the therapeutic plasma exchange reduces a lot of inflammatory factors in your bloodstream and can be useful for both longevity, but obviously we're using it for things like Alzheimer's, we're using it for things like PANS, and a number of other diseases that have autoimmune etiology. So there are things we can do to help you. There are things we can do to slow the progression of this disease. There are things you can do to help yourself and slow the progression of this disease and potentially prevent it. Once it expresses, it's a much tougher disease to treat. And unfortunately, to date, we do not have cures. But we do have potential for slowing its progression. And that's what we can focus on for the moment. I think it's important everybody know their ApoE genotype. Now, there are potential problems here. The potential problem is if you come up with an ApoE 4/4 and your insurance company takes a look at that and says, well, we don't know that we want to insure you because we know your risk is dramatically higher than the rest of the population. These are things you have to pay attention to. So it's not quite that simple. But the fact of the matter is, how are you going to take charge of your health? How are you, as a friend of mine says, going to be CEO of your health so that you have a good, healthy, vital life? Next slide, please.
Well, that brings us to the end of the presentation. Thank you so much, Dr. Gary. That was insanely informative, and I think we can all walk away feeling, I think, the big picture that we should check early and that it is preventable and that we really do need to take care of ourselves to reduce any risk. But for everyone here, we're just going to launch a closing poll while we kick up the Q&A. Just wanted to get your feedback on your experience with the webinar today. We hope that you learned something new. So feel free to just fill that out for us. We could always aim to improve how we share information with you. If you know of others that would benefit from this information, please do share this webinar with them. I will be emailing everyone the recording and again, some closing information on everything that we covered today. But thank you again, Dr. Gary. With that, we'll start our Q&A. So we had a bunch of questions that were previously submitted, and I will start with one that I have here. I think this is a really good one. If a loved one or a friend is in denial, what's the best approach to help them get evaluated or treated?
Well, obviously, if they're not willing to confront the possibility itself, and this is a terrifying disease, right? As I said, I know this firsthand. So trying to get a diagnosis feels like the sword of Damocles hanging over your head. I would encourage you to say to them, look, why don't you just go see your doctor? All right. For whatever reasons, you're having headaches, you're having problems with focus and concentration, you're dealing with brain fog, and let's see if, maybe you have a vitamin D deficiency or a B12 deficiency. Then I would call the physician and tell them that you're concerned about this. We're not allowed to give out information to you, but we'll sure as hell take it in. And so I think it's extremely important that you want to alert physicians as to what's going on. I will tell you the number one complaint of males who come into my office is that my wife told me to come in. So my next question is, so what is your wife concerned about?
Mhm.
And I also have people call me ahead of time with regards to their kids or their spouse or other people they're worried about and say, look, I'm concerned about this. So while I can't give you any information about them, we will take in a lot of information that you have. So please help be proactive because you may save somebody's life.
Amazing. Yeah, I think earlier the better is what I took away from today. Another question here, is it possible that statins are partly responsible for the rise in Alzheimer's?
Yeah, that's been going back and forth in studies. It's a good question. I think at this point in time, the answer is no. The most recent data says that statins are not creating a problem with Alzheimer's. We do know that they may, in fact, be anti-inflammatory in the central nervous system. And so, in fact, it may be quite the opposite that the statins are actually useful for us.
Awesome, thank you. And I want to get through as many as we can. It's 1:19, so I'm going to rapid fire here. Can chronic migraines with aura lead to cognitive damage?
So the short answer to that is yes. And so we want to be aggressive in treating chronic migraines with aura. We do know that if we look at chronic migraineurs on the MRI, we see white patches. So it's clearly doing damage in the central nervous system. So we want to, again, this is about prevention. So we want to be aggressive. And we have a lot of good options for treating headaches at this point in time, migraines in particular. So see your doctor and make sure you're getting the best possible treatment. You should not be getting migraines on a regular basis. If you are, you're undertreated, and there are things we can do about it.
Yeah, definitely. Another question here. Does having persistent tick-borne disease increase your likelihood of Alzheimer's or other forms of dementia?
A truly excellent question, and we don't know the answer to it. It's of
Wow.
concern because we know it's a neuroinflammatory disease, but we do not know whether or not that actually is a risk or not. So my recommendation is treat aggressively, do everything you can to get rid of uh, the tick-borne infections.
Yeah. And then do we have kind of similar, do we have enough data to know whether COVID is increasing dementia incidence?
I think that COVID can unquestionably trip off uh, Alzheimer's in somebody who's already moving in that direction. Uh, my wife basically was doing fine until she developed her first case of COVID and went downhill fairly rapidly after that. So I have firsthand experience seeing this, but the literature tells us the same thing. When you've got a chronic neuroinflammatory disease, any kind of infection, and especially COVID, is capable of uh, making it much worse and thus now knowable, whereas in fact it was just simmering under the surface. Does COVID cause Alzheimer's? No, but it can certainly push you over the edge.
Yeah, I like the Jenga analogy that we've shared before that different
Mhm.
things that are part of your history and your body and all of your health systems, one thing can lead to more, to everything being weaker, your structure being weaker, and then now it's more susceptible to other things. All right. We had a couple of questions on nicotine patches, what your thoughts are. There seems to have been a mind study that found protective effects, um, perhaps given the negative effects of anticholinergics. I don't even know if I said that right, but
Cholinergics.
yep. But yeah, what are your thoughts on nicotine patches for Alzheimer's?
I think a little too early to tell. I think that symptomatically they may provide some help. I don't know that there's any mechanism that'll suggest it will reverse the disease. But, you know, we'll take any edge we can and any improvement we can. Also, the nicotine patches are not without problems. They are addictive. The nicotine patches can create problems with heart disease and in terms of cardiac arrhythmias. So not for everybody, but I think a reasonable thing to consider as part of what you're doing.
Great. Question here. If you want to tamper down neuroinflammation, what about taking LDN?
So low dose naltrexone, which I'm obviously a great big proponent of, without question, that reduces microglial activity in the central nervous system. And there is an argument that we should be taking it on a regular basis, low dose, somewhere between 3.25 and 4.5 milligrams. So it has to be compounded. So yeah, it may be effective. I haven't got studies to prove it though.
That's good. Okay, and then what if you do think you're having mild cognitive issues, what kind of doctor should you see first?
Well, hopefully your family physician, internist, you should be able to talk to them and get a proper response. Neurologists are another group that you can go see. So um, get in and say, I'm worried about this. There's simple testing we can do. And there's also proper medical workup to make sure, oh, you know what? Your problem is hypothyroidism. Let's fix that and just give you a thyroid supplement. So don't hesitate to ask. Make sure you're being listened to. The other thing is make sure you're being paid attention to. Do not let somebody just dismiss you. I deal with people all day long with chronic illness who have been dismissed uh, by their physicians. If your physician's not listening to you, fire them and go find somebody who will actually pay attention to you and give you the time that you deserve in order to be able to get a proper diagnosis.
Yeah, I think also too, want to hone in, especially with May being Mental Health Awareness Month. A lot of people suffer from anxiety, depression, a bunch of other neuropsychiatric kind of conditions, and often just, treated as such or get it treated as such. But it is definitely worth checking to see if there's something underlying that could be causing that, since it seems to be such a rampant effect by a lot of illness. But I agree. I think seeing a doctor that can look deeper beyond the surface of, how your symptoms are making you feel. All right. Let me see. I know I have a few more here before we wrap. Can hypnosis help with memory issues?
Hypnosis can't help in terms of neurodegenerative disease and Alzheimer's. It can certainly help in terms of recovered traumatic memories and is useful for a number of other neuropsychiatric issues, but there is no evidence that it's effective in terms of slowing the progression of Alzheimer's disease.
All right. And we just have a couple more here. Is dementia reversible through diet?
Again, there is nothing we know of that will reverse this disease. We can slow it. We can potentially halt it from progressing, but and diet is extremely important. So don't get me wrong here. I think it's extremely important. But ketogenic diets have been shown to be helpful for some people. Uh, but the MIND diet and the Mediterranean diet, both consistently showing up in studies as effective and relatively easy to manage from a dietary standpoint. Ketogenic diets are tough to manage.
Absolutely. And then someone you talked about this in the webinar, but let's say you got diagnosed, what would you say kind of briefly is a path that one would have to take?
Well, again, the first step is optimize everything: vitamin D levels, B levels, your thyroid levels. Look at your C-reactive protein. Is there a chronic inflammatory process going on? So we want to make sure that we're treating and working all the edges, if you will. We want to make sure we've got you in a good, appropriate exercise program and diet. We want to make sure that you've eliminated things like smoking and alcohol. If you've got early cognitive decline, you've got no business drinking any alcohol whatsoever. So get rid of the modifiable risk factors, and then uh, it's then the path becomes a little bit trickier. I mean, basically, the neurologists are going to tell you to take the anti-amyloid drugs because it's pretty much all they have. There are studies you can get involved in. The studies are challenging because they're placebo controlled, and so you won't know whether or not you're getting the active drug. In fact, you won't get any information back in terms of how you're progressing or not, other than how you feel clinically. So, but the studies are there, and we need the studies, and we need people participating in them. We have studies going on at Georgetown. We have studies going on at Hopkins. So, getting involved in the studies, I think, is important. There are anticholinergic drugs, memantine, that can be very effective in terms of helping with symptoms. They don't slow or cure the disease. And then everything else we talked about in the lecture today.
Okay, someone mentioned a mast cell. It says discuss, but is there anything you have to say about mast cell activation syndrome?
So mast cell activation syndrome is kind of the great imposter, and it can show up in a lot of different ways. This is where there's over release. So mast cells are kind of show up as blue underneath the microscope. They release histamine, but they also release about 200 other substances. And so there's a lot of things that we can see with mast cell activation syndrome, everything from hives and skin rashes, but fibromyalgia, chronic pelvic pain, prostatinia, uh, as well as depression and cognitive issues. So mast cell activation syndrome is something that you need to consider as part of the rule outs and things that can be treated in terms of helping reverse your fatigue and your cognitive issues.
Got it. And then just last one, we have 60 seconds here. any prescription medicines that are safe and don't cause more cognitive issues?
Well, I mean, I think more to the point, any prescription medication can potentially create problems. Okay. It depends who you are, your individual biochemistry. But I also want to point out that over-the-counter drugs like Benadryl, we think is safe and benign. The reality of the matter is it can create very significant cognitive issues. So Benadryl is one thing I would consider not taking if you can avoid it. There are other non-centrally acting antihistamines that you can use. But sleeping aids of all kinds can create problems for you, um, especially taking benzodiazepines. And basically, the normal hypnotic medications that here just take uh, Lunesta. Basically, they don't fix the sleep patterns. What they do is they just get you more sleep. And so they may actually cause more harm than good. So, a lot of things you want to pay attention to that can actually be creating problems, and less is more.
All right, well, that actually we covered everyone's questions for today. So I think we had a very successful webinar. Thank you again, Dr. Gary. Thank you for everyone joining us today and taking time out of your day to learn more about Alzheimer's disease. We really hope that you share this information with friends, loved ones, especially if you have anyone you're worried about. And if you have any questions or want to learn more about the Kaplan Center for Integrative Medicine, again, Dr. Gary and his staff, everyone here is an absolute expert in treating chronic illnesses, complex illnesses that your typical clinician might have issues recognizing or treating effectively. So if you are interested in learning more about our services, please visit kaplanclinic.com or give us a call. And again, we offer TPE for Alzheimer's. We offer TB006 and any other questions that you might have regarding Alzheimer's, early cognitive decline, and general longevity. So please make sure to learn more about us. But other than that, we just wanted to share this with you. So thank you again, and we hope you are healthy and have a great rest of your day. Thank you.